Are you able, are you able to see the PowerPoint and not the presenter notes? Is that correct?
David, we can see your presenter slides. Yeah, notes.
Then it's fine. We will use go without. Here we go. All right. So, thank you very much for having me today. Looking forward to discussing with you our project, looking at changes and trends of timely post-discharge follow-up associated with virtual care onset. And so, we'll start with briefly going over the background and rationale, then going into some of our methods, as well as highlighting our results, and then spending the last couple of minutes hoping to get your opinions on a next proposed project related to transitions from hospital to home. And so I have no conflicts of interest to disclose, and this project was using admin data at ICS. So it's well known that the transition from hospital to home is a high risk period for children and youth. And children and their caregivers have expressed that the transition from hospital to home is actually one of their top priorities, given that they often express anxiety, confusion, and even a sense of abandonment when it comes to caring for, when it comes to leaving hospital. And so many different programs have been implemented to try to facilitate this transition from hospital to home with varying degrees of success. One thing that seems to be very constant across many different interventions, and that's recommended from a variety of healthcare organizations, is the use of timely post-discharge follow-up in this transition period. And so, although many feel that the transition from hospital to home might be more easily accessible with virtual care. The truth is we don't know whether virtual care actually does is associated with a change in obtaining timely post-discharge follow-up. Additionally, there are some concerns around whether virtual care is being delivered equitably in this manner. We know that virtual care is used more commonly amongst urban residing physicians, as well families from higher material deprivation do express more discomfort when using virtual care. And so, with healthcare organizations across Canada now recommending virtual care for many children who leave hospital to facilitate that transfer process, we want to ensure that it's being used, it is being delivered equitably and understand whether or not it's actually associated with a change in follow-up. And so, we set out to conduct a repeated cross-sectional study using an interrupted time series analysis, investigating whether the onset of virtual care billing codes was associated with a change in obtaining timely post-discharge follow-up overall and by specific equity factors, specifically rurality as well as material resource score, which is a marker of socioeconomic status. And so we looked at all Ontario children aged 0 to 18 years old that were discharged from hospital to home between April 2011 to June 2024. Our exposure of interest was the onset of virtual care billing codes, which coincides and is a marker of the uptake of virtual care. Our primary exposure is the onset of the current virtual care billing codes, which were instituted in Ontario in December 2022, with the secondary exposure being the onset of temporary billing codes that occurred in March of 2020, with allowing for a 3-month washout period to allow for virtual care infrastructure to develop at that time. Important to note that the current virtual care billing codes do provide slightly less reimbursement for virtual visits compared to in-person visits. Additionally, the billing codes can only be used by physicians who have recently assessed a patient in the prior 24 months. This is in contrast to the temporary billing codes that first exposure period, where there were no restrictions on who can bill for virtual visits, and the reimbursement was equivalent for in-person versus virtual visits. Our comparator was the time period before virtual care uptake, so before March 2020, when virtual care accounted for less than 2% of all ambulatory care visits. And our primary outcome was the monthly rate of timely post-discharge follow-up. And so the numerator was the number of children that received follow-up within 7 days of hospital discharge, with the denominator being the total number of patients that were discharged from hospital during that month. And so we used, this was a population level study using linked administrative data at ICS with all of these data sets. Our statistical analysis utilized an ARIMA model, and so the ARIMA model was chosen over the more commonly used segmented regression simply because the ARIMA model accounts for seasonality and it doesn't assume that the outcome changes in a linear fashion, which is all things that we expect. And so, as you can see in this example graph, we're looking for a change in level at the exposure periods, as well as a change in slope, comparing the pre-virtual care era to the current steady state virtual care era. And we're running this analysis across the entire cohort, as well as across the subgroups of interest. And so our study included approximately 730,000 children who were discharged home across nearly 520,000 children. The median age was 6 years old, and the majority of hospitalizations were due to medical causes. About 64% of hospitalizations due to medical conditions, 24% for surgical conditions, and 12% for mental health conditions. We see that children with the highest material deprivation, so highest material resource score, have higher proportions of hospitalizations compared to the other groups. And this table is simply just looking at comparing our exposure group, the baseline characteristics across the exposure time periods, and it's presenting the standardized mean differences across each exposure time period and showing that indeed the baseline characteristics across the time periods are largely the same, the only difference being higher proportion of psychiatric hospitalizations during that temporary billing code era. And so if we run to the interesting aspects, now our results. Here we're presenting the annualized number of children that received follow-up within 7 days of discharge from hospital across the 3 different time periods. And we see that follow-up rates, interestingly, actually stayed quite constant over time. Now, if we graph our primary outcome across our exposure periods and run our model, comparing the current steady state virtual care period compared to the pre-virtual care era, we see that there's actually no difference in follow-up in level or slope of obtaining timely post-discharge follow-up across these eras. And so the hypothesis that virtual care actually improves or is associated with an increase in access to care might need further investigations, and as we highlight here, it's not associated with a change in that timely post-discharge follow-up. Now, if we break this down by hospitalization type, now the proportion of children that received follow-up was quite constant across both medical and surgical hospitalizations. Interestingly, patients that were hospitalized for psychiatric conditions actually saw an initial uptake of virtual care during the an initial uptake of follow-up during the temporary billing code period, but then reverted back to its pre-virtual care era in now this current steady state period. And so if we graph this data, we do see that although there is a statistically significant change in level and trend of follow-up when comparing the current follow-up rates to pre-virtual care follow-up rates, as we see, the parameter estimates are so small that it's not believed that these are clinically significant differences in actually obtaining clinically relevant differences in timely follow-up across all 3 hospitalization types. Now, if we look at this through our equity lens, we do see a drop in follow-up over the different time periods for both rural and urban populations, which likely is due to the ongoing primary care crisis that was exacerbated by the pandemic. However, we do see that patients with rural follow-up actually have obtained timely post-discharge follow-up less frequently than those living in an urban setting. When we graph this data, we find no statistically significant change in follow-up rates in the current steady state period compared to the pre-virtual care era across the two subgroups as well. And then lastly, when we track when we look at material resource scores, we see that follow-up rates are quite consistent, are quite similar across all material resource groups or quintiles, and they see an initial drop with then an uptake in the current steady state period. And then when we look at again, when we graph this, we see no difference in follow-up rates in the steady state period compared to the pre-virtual care era. And so the last table I wanted to present was now amongst children that did receive follow-up within 7 days, how many of those follow-ups were done in a virtual manner versus in an in-person visits. We see that in the pre-virtual care era, less than 1% of all post-discharge follow-up visits were done virtually. Now, in this current steady state, 12% of all visits are done virtually, of all post-discharge visits are done virtually. When we look at the case mix group, so the hospitalization types, we see that the patients hospitalized for medical conditions actually receive less virtual follow-up than the other groups, with only 10% of follow-ups being done virtually, while the surgical and psychiatric specialists, they do follow-up in 14 to 16% of the time, while virtual follow-ups is being done quite similar proportions across the two equity groups, across rurality as well as material resource group, which is interesting given that it was hypothesized that virtual visits should improve access to care most for patients living in rural settings. But as we're seeing here, and in the previous results, there's actually no change in obtaining post-discharge follow-up in this new steady state era and with the onset of virtual care. And so, in conclusion, we find that the onset of virtual care billing codes are a pseudonym for a marker of virtual care uptake is not associated with a change in obtaining timely post-discharge follow-up across both clinical subgroups as well as equity subgroups. And so ongoing projects are needed to really assess whether virtual care is being delivered equitably as a whole. And so investigating whether virtual care is being used amongst rural populations equally or more so across different settings, not in just the post-discharge period, are necessary to understand whether virtual care is being delivered in an equitable manner. And I think it's also important to highlight that organizations such as Ontario Health that are recommending virtual post-discharge follow-up, that they acknowledge that virtual visits has not been associated with an increase in obtaining this follow-up. And so moving forward, and I'm happy to take questions on that project shortly. However, moving forward, we are planning to conduct an additional project where we just looked at the timeliness and equity of virtual care visits in the post-discharge period. However, now we want to assess the effectiveness of timely post-discharge follow-up. And so although timely post-discharge follow-up is recommended for many children that have been hospitalized, there's actually very poor quality data on whether timely post-discharge visits really do improve health outcomes and whether it's associated with a decrease in adverse events. And so we're proposing to do a target trial emulation. And as part of that, we conduct a hypothetical RCT. And so our project is hoping to look at all Ontario children between ages 2 to 18 years old that were hospitalized or that were discharged from hospital during this steady state virtual care era, who were hospitalized for specific medical conditions. And the reason we want to focus on specific medical conditions is because it's believed that follow-up might be beneficial for certain conditions, but not all. And so we want to better understand what conditions might benefit most from this timely follow-up. Our comparators are those who obtain early follow-up, so follow-up within 7 days of discharge, compared to those that do not obtain early follow-up. We'd follow the patients for 30 days following discharge for looking for our outcomes of 30-day readmissions or return to ED visits. And so the question I have for this group and would love your input is which conditions you feel would be relevant to study to address this question on whether timely or early post-discharge follow-up is associated with a change in readmissions and return to ED visits. We are proposing to focus on 4 acute and 4 chronic conditions, as highlighted here on the slide. The 4 acute conditions were selected as they're amongst the most common reasons for pediatric hospitalizations, as well as most costly. Bronchiolitis is not on this list, as there was an RCT that looked at bronchiolitis follow-up and readmissions, and there was shown to be non-inferiority between those who obtained follow-up versus those that do not obtain follow-up on readmission rates. And then the chronic conditions were selected because, yes, they are common, but it's also a feasible group to capture with validated patient registries, and they're groups that have high readmission rates, especially those with sickle cell disease. So maybe with that, huge thank you to multiple people, especially Astrid, Sanjay, and Peter. And maybe I'll stop there for some questions.
To David as well. So we'll move on to our next speaker, who is Dr. Eric Coon. And Eric's going to be talking on a related topic around a trial that Prize is conducting called I Decide. And Eric is working with Chris Bonafide on this multi-center trial. And what's exciting is they reached out to Peter about the potential for PIRN sites collaborating on this study. So part of the purpose for Eric to come and talk to us today is about whether sites within PIRN would be interested in participating in this trial. Many of you know Eric. Eric's a leader in PHM research, and he is currently in Seattle Children's. He is an executive council member for the Pediatric Research and Inpatient Setting Network and is a professor of pediatrics. And his area of research broadly is focused on high value care and pragmatic trials. So in a lot of conditions that are germane to our practice, such as intravenous antibiotic therapy, short versus long, high flow nasal cannula. And then he's run some really impactful trials pertaining to post-hospitalization follow-up. So we're delighted to have Eric come present. And Kinjal had sent, as part of the agenda item, a brief overview of the trial for your notes. And also, if you're interested, there's an email address there for you to reach out. So I'll hand it over to Eric to talk about this really cool trial.
Thank you, Sanjay. And David, awesome work. Really comprehensive look at this question. And it is very fortuitous that we're both presenting today on similar topics. It's wonderful. So yes, our new project is called I Decide, and really what it's focused on is trying to promote as needed post-hospitalization follow-up for children with bronchiolitis. Let's see here. This work is being led, as Sanjay mentioned, by myself and Chris Bonafide. Chris's area of expertise is really implementation science. He's also a hospitalist at Children's Hospital of Philadelphia. And it's been really awesome to work with him and his team. So as a result of this being a close collaboration between Philadelphia and Seattle, there are team members who are based in Seattle and those based in Philadelphia, and have them here because if you do choose to work with us, these are folks you may interact with. Allison Coons is our research manager. 2 research coordinators here in Seattle are Nettie Oviedo and Aya Sahib. On the Philadelphia side, Kenita Brent, who I think is in the audience today, as well as Kim Albanowski, Jess Wynn, and Max Gauthier. This work is being funded by PCORI, the Patient-Centered Outcomes Research Institute. Bring that up really because funding is really very much in flux in the States these days. NIH in particular being targeted. PCORI hasn't been as targeted, but anything's possible. Right now, we are told that it's full green light, full steam ahead on this work. But officially, our funding for this project starts in April. 5-year grant as well. Um, yeah, most importantly, like why are we doing this work? We're trying to change the status quo of at least how follow-up happens in the States, and it sounds like it's probably kind of similar in Canada, where our knee jerk for a long time has been if a child's hospitalized, they should go see their regular doctor in a few days. They were pretty sick. It's very logical that they should check in with their primary care provider, make sure everything's okay, maybe change management, tweak things. Um, but we've learned from Benefit, the trial that David alluded to, and some other studies that, particularly for bronchiolitis, it may not be necessary to always have automatic follow-up. And instead, we can pursue something we're calling as needed follow-up, where families are encouraged to follow their child's symptoms at home after hospital discharge and decide on their own if and when they need post-hospitalization follow-up. And I think as medical providers, we tend to underestimate sometimes the burdens that a follow-up might place on a family. They've just spent a lot of time in the hospital, away from work and other responsibilities. And now, if we say automatically go to a visit in a couple days, that's more time away from work and those responsibilities. There's maybe travel issues, particularly for families that live rurally. And there is some evidence to suggest that overtreatment is a risk of automatic follow-up as well. Really the findings from Benefit, again, David touched on this. Actually, before we get to that, I'll just kind of lay out the two groups that patients were randomized to in Benefit. One was automatic follow-up, where we say, go see your regular doctor a few days after just discharge, no matter what, even if your child's symptoms get better in the interim, versus as needed follow-up, which really focuses on empowering families. Like, this decision is in your hands. If your child gets better the way most kids with bronchiolitis do after discharge, you don't need to have a visit. But if your child's not getting better or you're worried about something, then absolutely schedule a visit. And I think that's an important point of as needed follow-up, is that the message is not don't follow up ever. It's just follow up if you really need it, and certainly continue to have your well child care. Doesn't preclude that. It was a non-inferiority design, and one of the biggest findings was that as needed follow-up resulted in families choosing to go to follow-up visits 62% less than families who are randomized to automatic follow-up. So a big drop in these visits when families are given the as needed follow-up instructions versus automatic. And then we found non-inferiority for our primary outcome, which was parent anxiety, asking the question of whether having that visit within 7 days might reduce a parent's anxiety after being hospitalized. And then non-inferiority on secondary outcomes, including readmissions and durations of symptoms, among others. So conclusion coming out of Benefit was that as needed follow-up is a very reasonable option for families whose child is hospitalized for bronchiolitis. Now, like a lot of research that happens, this hasn't necessarily changed practice right away. Again, most of this data is from the States side, but I'd be interested to. It sounds like, based on what David's presenting, that it's probably similar in Canada. But we know that as needed follow-up in the US is only recommended about 20% of the time. And about 2/3 of US children are still going to a follow-up visit within 7 days of discharge in the setting of bronchiolitis. This is after, the publication of Benefit and some other studies. And there's some observational data that also augments what was found in Benefit, showing that ED visits and readmissions are pretty uncommon, and don't differ between whether you have automatic follow-up or not. And then lastly, this is something I alluded to a few slides ago. Children who have follow-up after hospitalization for bronchiolitis are often prescribed medications like albuterol, steroids, and antibiotics that are not concordant with guidelines. These are therapies that we're trying to avoid in bronchiolitis. So there is a risk of overtreatment with unnecessary post-hospitalization follow-up. Our really overarching goal for IDECIDE is to figure out the best strategies to fully implement as needed follow-up and replace automatic follow-up for children hospitalized with bronchiolitis. Our key outcomes are adoption, so the extent to which prescribing of as needed follow-up is done. Secondly, sustained change in actual follow-up practice, so whether the child goes to a visit or not. And then clinical outcomes like readmissions, attendance of well child checks, whether these kids are still getting their needed immunizations. This is designed as a cluster randomized trial, so the hospitals are the units of randomization. It's not individual patients. Which patients are eligible for IDECIDE? This is basically modeled entirely off of the eligibility criteria for benefit. Children less than 24 months of age, the primary diagnosis needs to be bronchiolitis, and these children need to be discharged by a generalist inpatient service, so general pediatrics, hospital medicine, but not from an ICU or the emergency department or a step-down unit. We are excluding patients who have complex and/or chronic health conditions, and this sometimes happens in certain states. In the US, discharge with oxygen therapy, those patients would also be excluded. And important note is that it's completely okay if these patients have secondary diagnoses like asthma, pneumonia, otitis media, as long as the main reason for their hospitalization was bronchiolitis. This is the overall design of IDECIDE. So there's a lot going on here. There are 3 phases, phase 1, phase 2, phase 3. The purpose of phase 3 is to mostly get baseline data. Where is each hospital at naturally in the absence of any intervention in terms of recommending as needed follow-up or not, and the extent to which their patients go to follow-up visits or not. And a lot of that is because there's not too much, I think, point to a hospital participating in IDECIDE if they're already doing as needed follow-up for all their patients with bronchiolitis. It's a run-in phase, as well. So if certain hospitals just have trouble with data collection or some of the regulatory burden of participating, that can be learned upfront before randomization. So phase 1 will have about 50 to 70 hospitals total. And then randomization will happen between phase 1 and phase 2. The main arms, and I'll describe these in a little more detail in a coming slide, but the kind of 2 main arms of the trial are a moderate resource implementation strategy and a high resource implementation strategy. We're trying to figure out which strategy can best increase as needed follow-up for bronchiolitis. So it's mostly an implementation science trial. And then there's a washout period between phase 2 and phase 3 where we pull back those interventions and see how well the effects of the interventions are sustained in phase 3. And then you'll notice there is a third group that I'll talk about in a little bit, a concurrent control arm that was added as a result of feedback from grant reviewers. So there will be about 10 hospitals that they participate in phase 1, collect data, everything goes well, but then they do not get randomized. They just stay as control group that doesn't get any intervention and serves as just kind of what would happen in the absence of these interventions over time. Some details about each arm. So the moderate resource strategy arm has 3 main components. Educational outreach, which involves family-facing handouts, slide decks, and training for presenting to hospital staff. And this will all be provided centrally. Local sites aren't going to need to design these items. We will provide them. It'll probably be ideal if local sites adapted the um, outreach materials to what makes sense locally. And then we're going to be doing a webinar series where we just invite primary care providers from, anywhere that we can get a hold of to learn about IDECIDE as well. Again, where we would be presenting, the burden's not on the local sites for that. Audit and feedback is the second main component of this moderate resource strategy arm, where we're collecting data on rates of as needed follow-up prescribing and then giving that back to each hospital and stratifying it by patient race and ethnicity and patient spoken language. And then an EHR clinical decision support toolkit, where we would provide templates to integrate discharge order sets that focus on as needed follow-up, discharge instructions for as needed follow-up for families, primary care provider notification templates. The high resource strategy arm takes all those same components from the moderate resource arm and just builds on it with two extra pieces that have to do with facilitation. One is small group facilitation, where site leads would meet with members of our implementation science core on a monthly basis and some of their peers that are randomized to the high resource strategy arm, and really like brainstorm about what has been working well or not working well in terms of trying to move the needle on as needed follow-up for bronchiolitis. And then expert CDS coach-led facilitation. We've partnered with folks that are experts in clinical decision support and have agreed to provide one-on-one mentoring to some degree for site PIs. So not just having the toolkits, but they can really dig into like locally, what are the barriers to getting this into the EHR? And they're very experienced at navigating those barriers. And then again, the concurrent control arm, where it's just really focused on data collection each phase. There's no intervention happening. The work involved in each arm. So there would, to start with, be IRB reliance agreements. This is planned as a single IRB setup, data use agreements, and financial contracting. Here's a timeline. So, I've kind of gone over each of these phases, but we're hoping that phase one, we would be up and running by November of this year. And then each phase kind of runs over a bronchiolitis season. So November to April for phase one. And then there's in that in between phase one and phase two is when we would do the randomization, figure out who's in which arm, and have sites prepare for rollout of whatever strategy they're randomized to. And then phase two is where these strategies are in place, really pushing to promote as needed follow-up for children hospitalized with bronchiolitis. And then again, a washout. And then phase three, where we see how it's sustained. Data collection, what does that look like for a participating site? That is it's fully EHR chart review done by the site leads. All of the like parent reported survey data, which is part of this, is collected centrally by a team in Seattle that I introduced at the beginning of this presentation. And then the way we've submitted our IRB, and the way we're planning to do this is to have an option for parents to opt out um, of being contacted and having further data collection. And we are proposing multiple ways that could be delivered. One would be to just have flyers up in whatever units have patients with bronchiolitis, and families will kind of see them and see that they can opt out, as well as potentially giving flyers individually to families. And that might have to be tweaked according to whatever the local IRB, needs. But an opt-out is part of this. And then here is what the data collection flow would look like. The blue is what would be performed locally by site leads, and then the green is the central piece that's handled in Seattle. Really, what it is locally initially is just, again, giving families some way to opt out, and then putting enough demographic information into REDCap so that the central team can reach out to the families and consent them, do further data collection. That's the initial piece of what's kind of locally or local responsibility. And then there is a final chart review that happens more than 14 days after the patient is discharged to look at medical utilization that happened. And then the Seattle team, that's in this green box here, again, does the consent, surveys families at in the first kind of few weeks after discharge, and then again at 6 months to get some of the longer term outcomes. The primary outcome is adoption, the extent to which as-needed follow-up is being prescribed, and that is collected by just reviewing what's in the EHR. And categorized as laid out here. So whether a family was told to definitely follow up, only follow up as needed, maybe there's no recommendation, or some other primary care follow-up recommendation. And this is an important point here is we're shooting for about 30 patients per phase to have, kind of put into REDCap and then had data collected on per site. And again, our secondary outcome is focused on sustainment, which has to do with whether these patients go to their follow-up appointments or not. And that is ascertained in two different ways. One is by whatever you can see in your EHR, which might be nothing for some sites, or I'm guessing in Canada, maybe you'll have a nice view of whether they went to an outpatient post-hospitalization follow-up visit. So that's one source. The other source is that the Seattle team is contacting these families to hear whether they went to a visit or not. I know I'm getting Sanjay, let me know if I need to like wrap up pretty quickly here. And it's been about 20 minutes. Do I have maybe a couple more minutes or should I?
Yeah, maybe 1 or 2 minutes, and then we
Okay,
can.
I'll be really fast. Um, yeah, there's kind of two different pieces where a site lead would get into the EHR. There's the one where you get their demographic information initially so that the Seattle team can reach out. And then there's that one to do about 14 days after discharge to get the rest of their medical utilization. This is an important slide. What's in it for you, right? I think number one is being part of a fun community, working toward a common goal. Um, I don't know if any of you have participated in Chris's emo trial, but I think that there's a lot of camaraderie in getting involved in these multi-center projects. We have done MOC credit for places in the States, and that's maybe something similar we could try to pursue for participants in Canada. Meeting up at meetings is really fun. We do have a plan, it's in the budget to provide stipends to sites for participation. It wouldn't, just in full disclosure, it wouldn't be enough to have like a research coordinator, but it's several $1,000s per phase to sort of, say thanks for participating. Opportunities to take part in publications, like anyone can pitch ideas for sub-studies and then lead them with the data we're collecting. And then we're looking for folks to let us know if they're pretty interested or not by filling out this survey here, and we can send it around after the meeting. Be really ideal if we could hear in the next 4 weeks so that we can start moving on some of the regulatory paperwork. Thank you very much for being willing to listen to this presentation, and I'm happy to answer any questions.